Hi, welcome to my presentation. I'm Dr. Monde. We're going to talk about dental materials are very important because we use them each and every day. So we need to understand the science of dental materials, which involves a study of composition and properties of the materials which we handle and how they interact in the environment in which they are placed, which is mostly the mouth. So the selection of materials for any given application can thus be undertaken with confidence and sound judgment, especially for dental assistants. Usually you are the ones who set up the trays and then pick up the certain materials according to what the dentist is gonna use. So other materials that can be used, which can be used by the dentist, or sometimes can be used by the dental laboratory or technicians. And so you really need to require a thorough knowledge of the materials in order that they may communicate about selection, manipulation, and any problem which might rise. And there are some materials that are used by dental surgery, and you also have to be familiar with those. So in selecting dental materials, there is a logical sequence that we have to follow. First of all, we have to analyze the problem, then we consider the requirements, then we consider the availability of materials and their properties, and then the choice of the materials. And sometimes we can also consider the cost of the material, and also we can also consider if the patient is able to pay for the treatment. So we also have to consider. So according to the diagram, we see that we have to follow the diagnosis of the analysis, and then we go to the requirements. So the diagnosis, then we go to the requirements, we compare the requirements and properties, and then we select the materials, review, or sometimes we do the diagnosis, and then we check which are the available materials. For example, a patient comes and you have to do a filling for posterior teeth. And then in your clinic, you don't have composite, but you only have amalgam. So you might end up just using amalgam because that's the one that is available, or there's just GIC, so you end up using GIC. So it depends with what you have in your surgery. So that's why we consider also the availability of materials. It's not only in the clinic, but also nationwide. Like for example, let's say in Zimbabwe, sometimes they might have a shortage of a certain material, so you end up using what is available. The local anesthetic that we are so much used to, and the one that we commonly use is lidocaine or lignocaine that we are mostly common with. And also another one is the general anesthesia. That's the one that puts the person to sleep. And why do we use anesthetic solutions? We use anesthetic solutions so that the patient might not feel pain. So the solution numbs the area that we are supposed to. So for the different local anesthetic solutions that we have, usually comes in a small bottle and mostly 1.8 millimeters to 2 milliliters. So we have different types according to the brand names that I've mentioned here. There is xylestacine, there's also obestacine, xylotoxol, carbocaine, scandonest. These are different brand names. So they have different constituents that they have. So the common one that I've said is lidocaine that we use. So most of the anesthetic have lidocaine 2% and having also epinephrine. So epinephrine and can also be called adrenaline. So you just have to read on the container that comes with the anesthetic so that you'll be familiar with the type of the anesthetic that you are using. So for us, we are very common with the anesthetic with epinephrine and also the anesthetic without epinephrine, the one that we know as plain. Like when we're working, we just know that this is plain. So for the plain, we usually use it for people with hypertension, those with high BP or with BP problems, high blood pressure issues. So you have to ask the patient when they come, like, do you suffer from hypertension? If they say yes, then you have to check their blood pressure. And if it's high, we can't use this anesthetic with epinephrine because it will cause too much bleeding on the area. Why does it have epinephrine? Epinephrine acts as a vasoconstrictor such that less blood comes out when we are extracting. So that's why it's very serious to know the blood pressure of the patient, and you also have to know which one to choose. So you have to be familiar. When you are arranging your anesthetic, you have to know this side is for plain, this one is for with epinephrine. So you have to be very specific so that when you're picking, you know which one the dentist is gonna use. So we also use topical anesthetic. For topical anesthetic, we mainly use it for pediatric patients, for kids, because they are very scared of the needle. So we usually use it. So we usually apply it before injecting the local anesthetic. So for the topical anesthetic, we've got two common brands, Ultracare and Subtopical. So for this one, we apply it first. So if it comes in a container like this, you have to use a cotton bud, or you just an applicator. Then you play, and then you give it to the dentist, and then they'll apply it, and then it numbs the area that is to be anesthetized. Sometimes we can just use the topical alone. It depends with the condition, or we use the topical and the local anesthetic. It depends also with the dentist, with what they want. When we are taking the impression of the mouth, so we just take the impression like single mix. So for the double mix technique, but the double mix technique, it's very important to use, especially when you're doing crown preparation, because it's very accurate. And then the other one is the two-stage or the party wash technique. So for the two-stage, we're using perforated stock tray, we use the party and also the light body. So what happens is we first take an primary impression with a party in the stock tray, then it sets, and then we put it aside. Then we take the light body later on, we mix it, and then we put it in that impression that we have taken with the party, and then we place it in the patient's mouth, it sets. So we do it in different times. So that you first put the party, then it sets, then the light body, then it sets. That's why it's two stages. It's done in two stages. And then the different types of impression materials, we've got Alginate, and these are the different brands. I'm sure you're familiar with some of them. We've got Geltrade, we've got Chromopan, we've got Chromaphase, and then we've got COE Hydrofuel Gel. So these are the different types that we have, and there are the more brands of Alginate. So we have to be familiar. So what are the uses of Alginate? Alginate is using for making dental impressions, which are used for the fabrication of static casts, orthodontics models, opposing models, removable spleens, removable retainers, provisional restorations. There are some restorations that we have to do outside the mouth, and then we have to, after they are made, then we have to place them in the mouth. So that's what we call provisional restorations. Then for additional applications in the dental office, that's why we use algae. Those are some of the uses. And so alginate, it has its mixing and setting time. So it depends with the manufacturer's instruction. These are just examples. So we have for the mixing time, for regular set, so we've got two types of alginate. We have the regular set and the fast set. So for the regular set, it's take too long to set, and then the fast set, it sets faster as compared to the regular set. So you have to be familiar with the minutes that you have to mix it. So the mixing time has to be very, very short, 4 to 5 seconds or less than a minute. So you have to really mix very fast. I'm going to share with you some videos on how to mix later on. So you have to be familiar with how to mix and also the working time and the setting time. So you have to really mix it fast because it sets also fast. So you also have to be aware of the temperature of the water that you're gonna use. So cooler water increases the time and the warmer water decreases the time. So you realize that when it's very hot, um, your impression material, your alginate impression material is going to set very fast as compared when it's cold. So when it's hot, it's better for you to have some cold water and then you use it to mix it because it will help you to increase your working time because it will take too long to set. So it depends with the procedure. If you're working in the patient's mouth, let's say for example a kid, usually most of the kids, they're anxious, they want everything to be done faster, then yeah, you really need to decrease the working time. So you better use like warm water and then you put it in the mouth and then it can set faster. Or for a patient who's got a gag reflex, because some patients may actually vomit on you if it takes too long to set, so you better use warm water so that the working time is shorter. So it just depends with the environment and also the patients that you're. So how do you mix this alginate? So you have to set the tray. So there are different type of trays. So there are the large ones, the small ones, the medium sized one, or even the extra large one. So you have to pick the size of the patient's tray first. After that, you have to put your PPE in place. At the your PPE, you prepare the patient, and then you go to then you start mixing your material. So you dispense your material by dipping the supplied scoop into the powder. So most of the materials usually comes with a scoop and also a small cup. So you have to dip the scoop into the powder, then you pack it into the scoop. Using the spatula, you have to lay it across and level the powder so that it's not too bulgy, but it has to be level with the scoop. And then you place it in the mixing bowl. After that, you measure also the amount of water that you need to mix with. So normally we use 2 scoops for the mandibular and then 3 scoops for the maxilla because it's too big. But it also depends with the patient's size of the arch. So some patients will be using smaller trays, so you might even use 1.5 scoop of alginate. Since things are very expensive, sometimes it's good to be very economic. That's why we have the scoops for the measurement so that you don't just waste or just use as you please. So you have to be very careful and also economic when you are using this. So you add the water using the small cup of the measuring device that will be supplied. If you don't have, you can actually just run it by the water, and with time you'll be familiar, like this is the amount of water that I need to use. But it's better to use the scoop and the cup. It's easy. So after you've put the water and the powder together, then you mix it and incorporate it. It's actually better to use a figure of 8 when you are mixing. It removes the bubbles from the alginate. So once you've mixed the material into a creamy texture, then you put it in the impression tray, and then it's now ready to be inserted into the mouth. Another impression material that we've got the final impression or the rubber base. So for the rubber base, this is very expensive as compared to alginate. So it's used for taking impressions for the following: for full dentures, partial dentures, inlays, onlays, crowns, bridges. It's available in regular body, injection type, which can be light or also have a body and facet. And it comes in 2 types. There is the catalyst and the base. But you have to be careful because the base the base, it usually stains the clothes, so you have to be careful when you're handling it, and also when you're placing it close to the patient, because if it drops on the patient's clothes, you may stain them. And another material, for the example of the rubber impression material, we've got the polysiloxane impression material. This is the putty. It comes also in two types, the rubber and the catalyst and the base. So usually the one which is more colorful is the base, and the white one is usually the catalyst. So when you're mixing it, you have to get equal scoops of the putty, and then you mix it together. So it has to be the same amount, the same size. Or sometimes it also comes as the putty, and also the catalyst will come in a syringe. It depends with the type that you would have bought from the shops. So you just have to be familiar and also follow the manufacturer's instructions. So when you're mixing, you have to knead it together until a homogeneous mixture is obtained, and this has to be done very fast, in almost like 30 to 45 seconds. And then you place it in the tray, and then you give it to the dentist. But then the setting time takes about 3 minutes. So when you're mixing, you have to leave a little bit of putty or after you've mixed and put it in the tray, you have to leave a little bit of putty outside that to check if it has set. If it hardens in the patient's mouth, it will be hard to take it out. So you have to know about the setting time, so that you'll be able to notify the dentist that the setting time, that they will take it out. So another type is the hydrocolloid reversible or hydrocolloid impression material. Most people don't usually use this one. It's also super expensive compared to the other two that we have talked about. So you might meet it in practice or not, because most people don't usually use it. So it's used for the crown and bridge impressions, inlay and onlays, and it's made from water and ocean's agar. Probably that's why we don't really have it in Zimbabwe. I'm not so sure, I haven't seen it around. So the properties, it's wetness, small amounts of blood and saliva which do not affect the accuracy of the impression. It's available in syringe and tubes, and you also need to have the hydrocolloid machine. So if you don't have the machine, then you can't use it. So now we move on to restorative materials. Why do we need restorative materials? We need restorative materials so that we can be able to replace broken teeth, and also to fix having, or the patients will be having. So the first one that I'm going to talk about is amalgam. Amalgam, this was used, this is the one that was used from long back. It's one of the materials that we've been using in dentistry for a long time, and it is silver in color. It contains mercury. It's an alloy powder containing silver, tin, copper, and zinc. So we use mercury to mix the powder. So it's used in stress-bearing restorative material for posterior teeth. So in stress-bearing material, in stress-bearing surfaces, especially posterior teeth, because we use the posterior teeth to chew very hard stuff. So that's why we really need composite amalgam. Amalgam is very strong. So the properties are strong and durable material, corrosion resistance, reduces ditching. Ditching is when we have a little bit of holes in the teeth or in the material, filling material, so it is reduced ditching. And some of it comes with self-activating capsules, or sometimes you have to mix it. It depends with the surgery that you're working, or the clinic that you're working in, what type of amalgam that they have. So indications for amalgam use. Amalgam is used in all individuals of all ages. Even in children, we can use amalgam. It's used in stress-bearing areas of mouth, as I've mentioned before. It's used when there is severe destruction of tooth structure, and when the person has poor oral hygiene, and when moisture control is a big problem, like you can't remove the saliva in the mouth, you can't isolate very well, then we can actually use amalgam as compared to composite, because composite is moisture sensitive. So this one, it's used when moisture control is problematic, and also when cost is an overriding patient concern. Amalgam, it's a little bit cheaper as compared to other restorative materials that we have. So when should we not use amalgam? We should not use amalgam when aesthetic is important, especially in anterior teeth. You can't be looking at someone's teeth and you're seeing a little bit of brown showing up, or silver or blackish showing up. No, we don't use it for anterior teeth. And also when patient has a history of allergy to mercury or other amalgam components that I've mentioned before, tin, copper, and zinc. If the patient is allergic to any of these materials, then we can't use it. And also the cost of other restorative material treatment options is not a factor. Then we have to also consider other options. I don't have the picture of the pencil, but it comes with the mortar and the pestle. So you put the pellet first, and then you put the drop of mercury, and then you mix it. After you've mixed it, you have to squeeze out the mercury using a squeeze cloth, and then after you squeeze it, you have to remove excess mercury. That's what we call trituration, when you remove the excess mercury. And then after that, you give it to the dentist, and the dentist will then place it in the prepared cavity, and then it sets very fast, so the dentist has to work very fast. Then after that, he has to start pre-carving, and then after pre-carving, he has to do carving. So for carving, the objective is to remove the excess mercury during the carving and the pre-carving, and also to rebuild the anatomy of the tooth. So the tooth after the filling is done, it has to look like the normal tooth, as you can see in the picture. This is a premolar, and it's still, after the filling has been done, it still looks like the premolar. And also the contacts has to be the same, even the height, the width, everything has to look like the normal tooth. So that's why we do the carving. Then after that, we have to polish it to make it very shiny. So polishing is done after 24 hours, but I've noticed many people, they don't usually polish, but it's supposed to be done. If polishing is not done well, the filling is gonna cramp, it will become hard and brittle and rough, and then with time it will crumble, and then it will chip off or break off. So it is actually wise for the patient to come back. You have to advise the patient to come back, and when they come back, they actually have to pay for the polishing. Probably, maybe that's why they don't usually come back. But you have to advise your patients at the clinic or at your surgeries to really come back for the polishing, because it's very important. If you don't do that, the patient will come back within 2-3 years complaining that the filling is broken off. But amalgam can even last for almost 15 years or even more. So it's actually better to advise the patient. And after the filling is done, you have to give the patient instructions. They are not supposed to chew on the side of the filling for the next 24 hours. You have to tell them not to chew on the filling, otherwise it will break. So you have to really tell them not to chew. And also, if they've been anesthetized, you have to tell them not to eat for the next 2 to 3 hours until the anesthetic wears off. So you also have to give them those instructions, because they are very relevant for the patient. They have to really know that. And also, these fillings are the same as the tooth, so they have to really clean them, because some people would think that I have fillings, so I don't really have to clean my teeth. No, they still have to clean their teeth. They really have to have good oral hygiene, because the reason that we have to do this filling is because in the first place they kind of messed up in their oral hygiene activities, kind of. So we move on to composites. So composites are an example of tooth colored restorations. It's different from amalgam that we've talked about, which is silverish or blackish in color, but composite, it's white in color. So composite, when we apply it, we have to really choose the shade, the right shade of the patient, and then the patient will be actually happy. And some of the patient cannot really distinguish the tooth and the composite if it's done properly. So indications for composites. Composites, they withstand the environments of oral cavity, and they can be easily shaped to the anatomy of the tooth. They match the natural color of the tooth, and they can be bonded directly to the tooth surface. So those are the. And then how do we apply composite? So as I've mentioned before, you have to select the shade of the tooth. The shade is selected under normal light, or you can actually use the sun. Don't use the light on the dental chair when you're selecting the shade, because it will be too bright at the end. So you have to switch on the light, switch off the light of the dental chair, on the dental chair, then you choose the shade. If possible, you could actually take the patient outside and then give the patient the mirror and also make the patient to choose the shade of the color. So you have to be careful when also choosing the shade of the color. You are not the one who's choosing the shade of the color, even though you are very sure, but you just have to assist the patient. So you have to make sure the patient choose the color so that they are satisfied in the shade that they have chosen. But also, if you see that they're making a bad choice, that's when you have to chip in and also advise them on the right color, because sometimes they might not be familiar with the shades, and they might be also be overwhelmed or anxious being in the surgery. So you also have to help them to choose the right shade according to the tooth structure. So after you choose the shade, so the dentist will prepare the cavity and remove the caries, and then after that they will etch the tooth using acid etch for 15 to 20 seconds. After that, you have to prepare the suction, because they're going to use to rinse the edge. This is the edge, which is blue in color. So you have to suction very close to the edge. Make sure that the patient will not swallow the edge. So you have to be careful, and also make sure that the edge will not go on the other two that are not being prepared or being filled, because they'll be affected since this is acid. So after that, the dentist will dry the tooth and then apply bonding agent. Then you have to prepare, you have to make ready the light cure. After that, you give the dentist the light cure, then the light for 15 to 20 seconds, or sometimes you're the one who be light curing. Then after that, you then express the needed amount of the composite material onto the treated pad or in the light protected well. Always make sure that the composite is closed, because it's light sensitive. So you have to really. And then so the materials is placed in increments, so small increments, then you light cure, another increment, light cure, another increment, until the cavity is filled. After that, the material after that the filling is finished, and then it's polished using different type of base. So you also have to be familiar with the base that I. So for polishing and finishing of composite, there are different bases that are used, so you have to be familiar with them. And also there's also the strips that are used, the polishing strips, so you also have to put them on the tray for the dentist to use. So, and also you have to place the articulating paper. Articulating paper is used to see the places that are high on the impression, on the filling that was done. So when the patient bites, they actually feel that the filling is too high. So when they bite, the impression will okay on the tooth surface where it's high. That's the function of the articulating paper. So the dentist will actually reduce using different burrs. So we've got fine finishing burrs, such as carbide burrs or even diamond burrs can be used. And also we have super fine discs. If you guys don't have them, it's okay. Sometimes some dentists have them, some don't have, so it's still fine. So usually they use a slow speed handpiece, so you also have to prepare that, because during the cavity prep we'll be using a high speed handpiece, but now you have to place the low speed handpiece to use for polishing. When the patient is satisfied, then you have to give the patient instructions. They don't have to chew on the fillings that are recently done until after 48 hours. So you have to really tell the patient, like, please, please, please don't chew on this side, or else the patient will come the following day saying the filling has broken or the filling has failed. So you have to give them instructions, almost the same instructions as I've said. And another material is GIC, glass ionomer cement. Glass ionomer cement comes in powder and liquid. So it's used as a restorative material, as a liner, as a bonding agent, or as a permanent cement. So it's used in primary teeth, used for final restorations in non-stress areas, as an intermediate restoration. For example, we are doing root canal treatment. You can actually put it as a temporary filling so that the patient can go and come back. And also, let's say the patient has a sensitive teeth, but the pulp is still intact or is not affected. You can actually put it, and then the patient can actually go for 2 to 3 weeks, and then they can come when the pulp is not sensitive and it's healed, and then we put the final impression material. And it can also be used as a core materials for a build up. If you want to do crowns, we can actually use it as a core materials to build up the broken down tooth, and also as a long-term temporary restoration. Especially for pediatric patients, we actually encourage to use GIC. So the qualities of GIC: it has the ability to bind chemically to the teeth, and there's no need to prepare the tooth structure as extensively as compared to for amalgam and composite. So for this one, it depends also with the extensive of the caries. If they are not very deep, you don't really need to make a very deep prep or hole. You just have to remove the caries and then you place it. It is also fluoride releasing properties after setting, which will help to heal the pulp. That's why we use it as an intermediate restoration when the tooth is sensitive, because of its releasing fluoride properties. So you have to be familiar with this property. And also that's why we encourage it to be used for children, especially for pits and fissure sealants, because it will actually arrest some of the caries. So as I've said, it comes as a powder to liquid. Some of it comes as a powder in liquid form, and there's also a type that is light protected tubes. Some comes as a paste system, and some as pre-measures caps. So it depends with what you are using in your surgery. So you have to be familiar with how you manipulate. So directions for the powder and liquid system. You have to gather the the paper pad, the cement spatula, and also it comes with a scoop. It's very small scoop for the powder, and then you have to have gauze also on the side. So when you are using GIC, you always have to make sure that the cap is always closed, especially for the liquid and also for the powder. So you open the powder, then you take the scoop. So it depends. You have to also look at the size of the cavity. If it's a small size, you just need 1 scoop. If it's big, you also add the amount of powder that you have to use. So when you're mixing, let's say for the base and the temporary filling, you have to use the measurement 1:1. 1 measurement of powder is to 1 measurement of the liquid. So you use 1 scoop and 1 drop, and then you mix. But if we're doing using it for the cementation, especially for a crown, you use one scoop of powder to 2 drops of liquid. Then you mix. So also it sets very faster. So the mixing time has to be 30 seconds or 30 to 45 seconds. So you have to really mix it faster. And then so we have what we call temporary restorative materials. These are designed to maintain or restore the function of the tooth or teeth and keep the patient comfortable for a period of time. I've mentioned it before that when the tooth is sensitive, we can actually put some temporary filling and then wait for some time until the tooth is healed or the pulp is healed or regenerated, and then the patient comes. If the patient is not feeling pain, then we can remove the temporary filling and put the permanent filling. And it can also use to maintain the function and aesthetic of the tooth until a permanent restoration can be placed. Let's say a patient comes and you don't have the final restoration like composite or amalgam. You can actually just put the temporary filling so that food might not get in the cavity or anything might not get in bacteria. So you just have to put the temporary restoration, and also to prevent shifting of the adjacent opposing teeth because of the open space. So that's the uses that we have for materials. So for the directions, you have to follow the manufacturer's instructions because there are different types of temporary restorative out there. So one of the common one is Cavid G. So for Cavid G, you just have to get the scoop and then you scoop it out and then you give to the dentist. You also have to know the amount to use. You have to look at the cavity. If it's very big, then you use a big amount. If it's small amount, you don't have to. We have another one which is called temp bond. Temp bond is usually used for temporary crowns, bridges, or splints, or for trial cementing of permanent restoration. And one of the common brands is Care, and it usually sometimes it comes as a syringe type. So you just have to take the syringe and then give it to the dentist, and then they'll place it in the patient's mouth, and then they'll put the temporary crown or the bridge or the splint, and then they wait for the setting, and then they're good to go. And then we have what you call intermediate restorative material, IRM. It's also an example of temporary restorations that are used. This one contains zinc oxide, which gives strength and durability, and it also have eugenol, which has a sedative effect. So it's actually better to use this one when you're doing root canal treatment, especially for very big cavities which have periapical or perio infections. So if you use this one, because of the sedative effect, it actually have some good healing properties. So the uses for restoration of primary teeth, restorative of emergencies, caries management program. So it comes sometimes as powder and the liquid, or sometimes as pre-measured capsules. So it depends with what you have. For pre-measured capsules, you just have to dispense the capsule and that's it. For them, one for the powder, you really have to know how to mix it. Instructions. It's almost the same as the way you mix GIC. So 1 drop of liquid to one scoop of powder, and then you mix. You have to really mix faster. almost 1 minute, and then it's now ready to be placed in the patient's mouth. And another one that we have for the timber, for this one we use it as a liner. Dical is the brand name, but it's called calcium hydroxide, but we are very familiar with Dical, but actually it's called calcium hydroxide. So Dical is the brand that supplies calcium, but there are other brands besides Dical, so we really have to be familiar with this one. So this one really sets faster, so it comes as a catalyst and a base. So you have to mix the same amount of the catalyst. You put 1 drop of the catalyst and 1 drop of the base, and then you really mix very fast. This one sets very fast as compared to all the other materials that we've talked about. So you have to be sure that the dentist is ready for calcium hydroxide, and then you mix it very fast, and then you give it to the dentist as quickly as possible. So you have to place it on the Dical applicator. This is the Dical applicator with the Dical instrument, or if you don't have, you can just use an explorer after mixing the toothpaste, and then you give to the dentist. So we have this type of medication when the patient has sensitivity for the tooth. So we have what we call desensitizers. So desensitizer is an agent used to reduce or eliminate the sensitivity of the teeth. So sensitivity may be caused by exposed dentin from abrasion, caries, abfraction associated with bruxism. There's some people when they are sleeping, they will be biting on their teeth, so they end up having abfraction. And then for abrasion, there's some people will really use very hard toothbrushes, and they think that when you use very hard toothbrushes, you're actually doing good for the teeth, but actually you are removing a lot of enamel, and the dentin will be exposed, so the tooth will end up being sensitive. So you actually have to advise the patients not to really brush their tooth very severe, and also to keep on changing their toothbrushes every 3 months. So you really have to tell them that, otherwise they'll come back complaining of sensitivity. So when sensitivity happens when you drink hot stuff or cold stuff, then the tooth will actually react to that. So also scaling, if it's not done very well, so even for the dentist when they're doing scaling, or even the assistants, some assistants actually do scaling, I've seen them. So when you're doing scaling, you have to be careful not to remove most of the enamel, because we really need the enamel to protect the dentin and also protect the pulp. So if the enamel is removed, the pulp will almost be exposed, leading to sensitivity. So we have to be very careful. And also there's some restorative materials that might fall and leading to sensitivity. So there are different types of desensitizing agents. The most common ones are toothpaste. For example, Sensodyne is the most common one that is used, and also Colgate now has some desensitizing effect in their toothpaste. So you actually have to read the toothpaste and check if they have the properties that you are looking for. So you could actually buy some toothpaste if you have sensitivity. We also have what you call fluoride gel or varnish that can be applied, and then the patient goes home. After some time, they will be feeling much better. So for the varnish, it has to be applied at least 3 times, depending with the sensitive. So the patient can come this week, we apply it the first time, they go back, they come back next week, and then the third week. So every time when they come, you have to ask them, is the sensitivity getting better or is still the same, so that you really know if your varnish is working or the gel has worked. We also have some inorganic salts or also resin agents. So another pain medication that we can use, especially after surgery, we can use dry socket paste. Sometimes the patient, if they're not able to take care of them socket after extraction or the wound, that will be there after extraction, they'll end up coming with what we call dry socket. So you really have to give proper instructions and make sure that the patient have understood the instructions, and so that this issue might not happen. So it can be called alveolitis or dry socket. So when they come with dry socket, they'll be in so much pain, and the pain feels like there is a tooth, there's something that was left inside the socket. Even though they've seen the tooth that was extracted, they'll still come back and complain and say, you guys, you left something inside my mouth. So you really have to give them the instructions. So if the patient comes back with that complaint, you just have to really know that this is dry socket. And also, when you look inside the socket, is very dry. Instead of the clot forming to heal the wound, there will be nothing, so the bone will be exposed. That's why it's very painful. So we have to use what we call the dry socket paste to ease the pain. So for the dry socket paste, we've got different type. We've got what we call Alvogel. This is the most common one, and the others that are out there: Alvocare, Alvogel. So you really have to be familiar with this one. So the properties of this dry socket paste, it's easy to use. It actually gives instant pain relief. When you use it, the patient will actually tell you, the pain is relieved, and only one treatment is needed. So when they just come once, you put it there, then that's it. So the socket has to be prepared, and then after the socket is prepared, you have to disperse the dry socket paste you have to remove the lid, and then you disperse it and give it to the dentist. Usually use a cotton plier or a tweezer, and then you give it to the dentist, and then they place it in the mouth. So the material will remain there in the socket for 3 to 5 days, and it actually comes out as soon as the socket heals. It doesn't have to come back. Now we move on to endodontic materials. That's our last section of dental materials for this section, for part 1. We have the part 2 on the next lecture. So for the endodontic, we've got irrigation solutions. So these endodontic materials are used for root canal treatment. I am sure all of us are familiar about root canal treatment. So for this one, we have irrigation solutions. So the commonly used irrigation solutions are water. You can use water if it's clean. Saline. This is water with salt. That's normal saline. It is water plus sodium chloride. And then local anesthetic can also be used. Sodium hypochlorite, 0.5 to 5.25%. We've got chelating agent, for example, EDTA. We've got antibacterial agents such as chlorhexidine, mouthwash, the one we use as the mouthwash, or acids, 30% of hydrochloric acid, or some detergents such as sodium lauryl sulfate. So the most common used ones are sodium hypochlorite, chlorhexidine, and hydrogen peroxide. I forgot to put it there, but we also use hydrogen peroxide. But if you don't have, you can just use saline or even water, or even the local anesthetic can be used. The sodium hypochlorite. So the sodium hypochlorite, you have to know how to mix it, 1:3. So your assignment is to tell me, how do you mix it for root canal treatment? How do you mix sodium hypochlorite and water? You have to dilute it. So how do you dilute it? So you have to tell me or write it down and give me as also the hydrogen peroxide. It can also be used as a mouthwash, and also used for periodontal treatment after root planing, and also can be used as root canal irrigation. So you have to give me the concentration. And even right now with the COVID, 19 that is occurring right now, hydrogen peroxide is mostly used. So you have to tell me, how are you going to mix this as an irrigation solution for root canal, for periodontal treatment after root planing, and also as a mouthwash before you treat the patient to avoid exposure to COVID? How do you mix it? So those are the three questions for hydrogen peroxide, and then the other one was for sodium hypochlorite, but I'm going to write down them and then. So we're talking, now we move on to chelating agents. So for chelating agent, we have EDTA, we've got the 17% and also the 15%. So for the 17%, it's a water-soluble base. It easily removes calcification. So during root canal treatment, the canals might be calcified and hard to manipulate. So we need to use the EDTA. So it's actually user-friendly. So it comes in a small bottle, but you have to put it in the syringe. And we also have, it contains citric acid, and it's used for root canal as a root canal irrigation solution. So there are two common brands, Glide and RC Prep. You have to be familiar with them. And then for medicaments for the root canal, we use sodium hydroxide. This is used as a disinfection solution, and it contains 3% sodium hypochlorite as well. And then we have UltraCal. It's also calcium hydroxide paste. It's radiopaque and high pH. So this one is used as pre-medication. So after the first visit, so the root canal can be done in 2 visits. So after the first visit, the dentist will put pre-medication, especially if the canal is infected or the patient is feeling too much pain. So the dentist would actually put some pre-medication. So we use calcium hydroxide paste as one of the pre-medication during root canal treatment. Another one, this is most common, is Cresofen or Formocresin. It depends with the brand name. So the most common one we use is Cresofen. So it's used as a germicide or disinfected in root canal prior to obturation. So before obturation, we use this Cresofen. And also it's used as a dressing in root canal and also as an antiseptic property. So this one, it will help to heal the canals, and also to kill the bacteria that will be inside the canal. So we use it for intercanal treatment during the first visit, while we are waiting for the second visit or the obturation. So it is put on the cotton pellet and placed in the canal, in the cavity, and then we put the temporary filling on top, and then the patient will have to go home and come back next week, so that they go along with the gutta percha points and also the size of the. So the dentist will tell you the size that they need and also the amount. So they may say we need 30 by 2, 35 by 4. So you really have to be familiar with those terms so that you know like what to give the dentist. So if they might say paper points 30 by 2, so you give them paper points. Gutta percha 30 by 3, then you give. And we also have scaling and polishing dental materials that we have. So after scaling and polishing is done, we have what you call prophy paste. So we use the prophy paste to polish and smoothen the tooth after scaling. The tooth have to be smooth so that plaque will not stick on the tooth. Usually plaque sticks on rough surfaces of the tooth. So after the routine scaling is done, usually it's done every 6 months. You have to also advise your patients when they come that they have to come for scaling and polishing every 6 months. So after scaling is done, then you have to dispense a little bit of amount of prophy paste. So prophy paste usually goes with the prophy cap, and then you put it on the low hand piece, and then the dentist will then smoothen and polish the tooth, and then the patient will rinse after, and then they are good